Good morning. I am Dr. Vishwaja, Professor and Head of the Department of General Pathology, SRM Dental College, Ramapuram. Today's topic in e-content series is disseminated intravascular coagulation. Disseminated intravascular coagulation, as it is popularly referred as DIC. The definition of DIC is as follows. DIC is a condition which is also termed as defibrillation syndrome or consumption coagulopathy. It is a complex thrombohemorrhagic disease which occurs as a complication secondary to the onset of systemic diseases. Following the definition, next we will discuss the various etiological factors attributing to the onset of DIC. The most important cause listed are as follows. Number one, massive tissue injury. This generally occurs as a complication following any obstetric procedures such as abruptio placenta, amniotic fluid embolism, placenta previa, etc. Sometimes a dead retained fetus can also give rise to the onset of DIC. The secondary causes following the obstetric procedures include massive trauma, metastatic malignancies following surgeries, septicemia or uncontrolled infections, especially caused by gram-negative species and meningococci, certain viral infections, malaria, and aspergillosis can also attribute to the onset of disseminated intravascular coagulation. Certain cardiovascular conditions such as aortic aneurysms can also result in DIC. The other major causes attributed to the onset of DIC include severe burns, acute glomerulonephritis, hemolytic uremic syndrome. The miscellaneous causes listed are as follows. Number one, following any snake bite, cobra venom, shock, acute intravascular hemolysis, and finally heat stroke. All these can also attribute to the onset of DIC. Next, we will discuss the pathogenesis of DIC. The pathogenesis of DIC can be discussed under the following headings. Number one, activation of coagulation system. Number two, thrombotic phase. Number three, consumption phase. And number four, secondary fibrinolysis stage. Now, coming to the activation of coagulation, the first stage or phase in the pathogenesis of the occurrence of DIC, the various etiological factors which we have discussed above can lead or initiate the widespread activation of the coagulation pathway, thereby resulting in the release of tissue factor. For example, following surgeries or any sepsis, there could be release of tissue thromboplastin. This tissue thromboplastin in turn activates the extrinsic coagulation pathway, thereby resulting in consumption of the clotting factors and platelets, leading to the onset of bleeding. The second phase is the thrombotic phase. In this phase, there is damage to the endothelium of the blood vessels. This generally occurs following a thrombogenic stimulus, which causes the generalized platelet aggregation and addition, thereby resulting in the deposition of small thrombi and emboli throughout the microvasculature. The third stage is the consumption phase. In this phase, the early thrombotic features which we have discussed in the second phase, that is thrombotic phase, is followed by the phase of consumption of all the clotting factors along with the platelets. Thus, the plasmin gets activated, resulting in fibrinolysis, thereby giving rise to the onset of formation of FDP, that is fibrin degradation products, finally resulting in the platelet aggregation thrombin and fibrin polymerization, which gets inhibited. Once the platelet aggregation, thrombin and fibrin polymerization gets prevented, it results in the onset of bleeding. Now, the last phase is the secondary fibrinolysis phase. This is generally a protective mechanism where, following the onset of the fibrinolytic pathway at the site of the intravascular coagulation, there is breakdown of fibrin resulting in the formation of FTPs. This FTP finally results in the onset of bleeding. Next, we discuss the clinical features of DIC. Now, there are two important features of DIC. Number one, bleeding, which is the most commonest manifestation of the disease. Number two, organ damage. This organ damage primarily occurs due to the onset of ischemia, which is caused due to widespread intravascular thrombosis, which is primarily detected in the kidney and in the brain. The less common manifestations include microangiopathic hemolytic anemia and thrombosis, which is generally seen in the major arteries and veins. Now, the platelet aggregation further leads to the intrinsic coagulation pathway, which gets activated, resulting in microvascular occlusion, and finally resulting in tissue injury and onset of microangiopathic hemolytic anemia. Next, we discuss on the laboratory investigations, how to detect a case of DIC. Now, some of the important investigations include number one, the platelet count, which is generally very, very low. This is mainly attributed to the onset of bleeding. The second important laboratory investigation includes the peripheral smear or the blood film, which depicts features of microangiopathic hemolytic anemia, wherein there is presence of cystocytes and numerous fragmented RBCs, which indicate damage during the trapping and passage through the fibrin thrombi of the RBCs. Next, we also ask for investigations such as prothrombin time, thrombin time, and activated partial thromboplastin time. All these three are prolonged in nature. The next investigation is the plasma fibrinogen level. Now, the plasma fibrinogen level is generally reduced due to the consumption of the factors in the microvascular coagulation. And finally, we ask the patient to undergo the FTP study, the fibrin degradation products study, which is generally markedly increased due to the onset of secondary fibrinolysis. Finally, we discuss the treatment of DIC. The most important major treatment involved for these patients is supportive therapy, which includes the replacement of the blood clotting factors which have been consumed. This also includes plasma transfusion or blood transfusion, which can be given to the patients who present with massive bleeding. This is followed by platelet replacement therapy, and finally cryoprecipitate, which contains the fibrinogen, and fresh frozen plasma can also be given in order to combat or replace the coagulation factors which have been lost during the process of bleeding. With this, we conclude the e-content series, and we will meet again in the next session. Thank you.